For the next half hour, we're going to be talking about pediatric nausea, vomiting, and diarrhea. If you work in an emergency department or an urgent care center, you know that this is a very common presentation to the emergency department or UCC. Now, children can present fully hydrated and looking great with they threw up once, or they can be in hypovolemic shock, and everything in between. And our treatments are tailored to the degree of shock or dehydration that they have. And so it might be that you have to get very aggressive and get high volumes of IV fluids, or it might be a pat on the head, some reassurance, and say, this too shall pass. So we're going to look at the mild to moderate dehydrated children. We're not going to look at the severe dehydration. So let's focus just on the mild to moderate dehydration in this lecture. And there's a couple of points I want to make before we dive into some of the abstracts. The first thing is the term acute gastroenteritis or AGE is frequently used to describe this group of patients. But we have to be careful that we're using it accurately. Does the child actually have vomiting and diarrhea? Because if they don't have diarrhea, it's just gastritis. And if they just have diarrhea, it's enteritis. And so you don't want to be documenting gastroenteritis when there's no sign or there's no documentation that they had diarrhea at the time of presentation. The other thing is when you use acute gastroenteritis, this can lead to something called anchoring bias. And this is a type of bias that anchors us to one diagnosis while we ignore other information that may steer us away from that diagnosis. And so a better approach to these children that come in with nausea, vomiting, and diarrhea is to describe their symptoms and then start thinking about the differential that goes with it. Because the classic miss is the child that comes in with just vomiting, so gastritis, just vomiting alone, and it turns out that it's DKA. It's a first presentation of type 1 diabetes. But because of anchoring bias, and we see gastroenteritis all the time, we document gastroenteritis when there was no diarrhea, and we don't think broader, and we send that child home. And in fact, that child is in DKA because of a first presentation of type 1 diabetes. So let's not make that mistake. So again, this chapter will not discuss those children that are in shock secondary to dehydration. Those children are defined as having a greater than 10% dehydration, and they present with a rapid pulse, cold extremities, poor skin turgor, sunken eyes, anuria, and generally an altered mental status. Let's put those aside. These are not the children we're talking about. These children who are severely dehydrated need 20 to 60 mils per kilogram of IV fluid to correct their underlying volume depletion, underlying glucose, electrolyte disorders, and you got to be thinking in those severe kids, DKA or a adrenal crisis, an Addisonian crisis of some kind. So let's again put that aside. We're going to focus in on the mild to moderate. And the majority of children that present to our emergency departments and urgent care clinics have mild to moderate nausea, vomiting, and dehydration. So that's less than 10% dehydration. And I'll put a table, or there is a table in your manual to look at that. Now, it's fairly evident that treatment for these patients require fluid. They're dehydrated. But the question that we're going to go through is, what kind of fluid? How do you get it in there? And how do you make it stay in there when you're giving them that fluid? So the first question is IV or intravenous fluid replacement necessary in a child with mild to moderate dehydration? So we're going to go back to my favorite era, the 1980s. This first abstract is from 1985. And this was one of the original studies looking at oral versus IV fluid rehydration. Small-ish trial, 100 children randomized into IV or oral. So there were 50 in each group. 3 children in the oral rehydration group did not improve like the IV group. 3. So that means 47 out of the 50 children did. The oral rehydration also had faster correction of their acidosis. It was safe, less expensive, and more convenient for the staff. So now that we're going to pop forward 20 years, And this is another randomized control trial looking at oral versus IV, smallish, 76 children, and the children were from 8 weeks to 3 years of age. So these are smaller or younger children with moderate dehydration due to viral gastroenteritis. That's the cohort that's in this study. Now, oral rehydration was just as effective as IV fluids, but you had less hospitalizations if the child didn't have an IV, and parents seemed to prefer oral better. The next question is, what's the proper composition of the oral rehydration therapy solution? Does that oral rehydration have to be some proper osmolality, the correct amount of glucose, sugar, the right amount of electrolytes? Most common electrolyte solutions that are commercially available are expensive, and they don't contain enough sodium for rehydration. Now, they contain enough for maintenance compared to the World Health Organization recommendations for the types of fluids. So again, in your manual, you will see a table laid out with the World Health Organization recommendations for the carbs you need, the sodium, potassium, chloride, base, and osmolality, and then a number of electrolyte solutions, plus apple juice and Coke. So the use of non-glucose containing carbohydrates have been shown to be more effective than glucose containing solutions. These solutions maintain a lower osmolality recommended by the World Health Organization with higher, more slowly released calories. But these fluids only have limited commercial availability, and like I mentioned earlier, they are expensive, so there may be a cost barrier to using them. For usual diarrhea in developed countries, glucose-based oral rehydration therapy is generally fine. So abstract number 4 is a systematic review and meta-analysis from the Cochrane Group. They were able to identify 35 trials with over 4,000 children, and they compared a polymer-based with complex carbohydrates oral rehydration therapy. So one of them had complex carbohydrates with low osmolality to a glucose-based oral rehydration therapy. And remember, the glucose-containing ones, the concern was that they had a high osmolality, and it was for acute watery diarrhea, so the enteritis. The polymer-based fluids, now they are usually rice-based, were associated with less diarrhea in the first 24 hours. So this seems good, right? Less diarrhea. If you're a parent taking care of a child with diarrhea, less diarrhea is better diarrhea. But how much was it? It was 1 milliliter per kilogram. It was 24 mils per kilogram over a 24-hour period. So I just did that math in my head. So it was 1 cc less of diarrhea per kilogram of body weight of the child. Now, the duration was decreased by 8 hours. So again, if you're taking care of a child with diarrhea, less time having diarrhea is better. 8 hours seems significant, but it had super wide confidence intervals that went from 13 hours to plus 4 hours. And it wasn't statistically significant. It crossed the line of no difference. The analysis was a little underpowered. The problem with commercial availability I did mention, but my biggest issue is this a POO? And yes, we're talking about diarrhea, so is this a patient-oriented outcome? A decrease of 1 cc per kilogram per hour. Is that significant to the parents? All right, traditionally parents have been warned not to treat diarrhea with apple juice. When I was growing up, that was the training. Apple juice, high osmolality, high glucose content, and it's in the table. It shows you that glucose content and that osmolality, high in calories, high in osmolality, and lacking electrolytes. But don't be so fast. Be a skeptic. Don't just take everything that you were told and taught without going, I wonder if that's true. And this is one of my favorite papers, not just in this lecture, but that's been published in the last few years. So this is abstract number 5, and it's a fantastic article by Dr. Friedman et al. He does some great work. It was a single center, so it is limited that way, a tertiary care pediatric center in Canada, and it was gastroenteritis with minimal dehydration, and the children that were included were on average just over the age of 2. Participants were randomly assigned into two different groups. They had half-strength apple juice, right, and preferred fluids, so that's what they got to drink. They got half-strength apple juice in the emergency department, and then were encouraged to drink the fluid of the child's choice. And they compared that to an apple-flavored electrolyte solution. They had just over 300 children in each group. 2/3 were without evidence of dehydration. Again, these are in the mild to moderate zone that we typically see. The children that were administered the half-strength or the dilute apple juice experienced treatment failure, and they define that as, needing an IV and stuff like that, but treatment failure less often than those given the expensive electrolyte solution. And in fact, the half-strength apple juice patients got an IV rehydration 2.5% compared to 9% of the children that got the electrolyte solution. Now, this study was set up as a non-inferiority study. They wanted to see if half-strength apple juice was non-inferior, not worse than the gold standard, this electrolyte solution. And in fact, when they ran the data as a superiority trial, they found that the half-strength apple juice was actually superior to the electrolyte solution. And so they concluded for mild to moderate dehydration, the expensive electrolyte solutions is playing on parents' anxiety and fear, and they're not needed. Apple juice, half-strength apple juice, and tap water, it's cheap, and then they can go on to the fluid of choice. Now, when I was thinking back about this study, I went, I wonder why they found that it was superior. And then I thought, I've tasted those electrolyte solutions. They're salty, they have the electrolytes in them. And so if you've got the perfectly formulated osmolality, carbs, but electrolytes, and you present it to the child, and if they don't drink it, it's not going to help. And so if they're drinking something, half-strength apple juice, and what they want, and they've got mild dehydration, that's better than having a fancy electrolyte solution and not even drinking it. All right, what about antiemetics? Are they useful in oral rehydration therapy? So oral rehydration therapy, it's not going to be successful is when you pour it in and immediately after, it comes right back up again. And so abstract number 6 looks at the utility of a drug that's changed my practice, Ondansetron, in the treatment of acute gastroenteritis. So it was a double-blinded, placebo-controlled, prospective, randomized trial. A lot of good words in there. It was a convenient sample, so there could have been some selection bias. The subjects were 1 to 10 years of age, and they had to have acute gastritis or acute gastritis who failed oral treatment. So they're taking the children that had already failed. And I'll tell you, the children that fail oral rehydration therapy is probably in the order of about 1 out of 5 to 1 out of 4, 20 to 25%. Now they received weight-based dosing of Ondansetron, that's 0.15 milligrams per kilogram in a dissolving tablet or a placebo. And 22% of the patients who received Ondansetron required IV hydration. And then 55% of placebo subjects who had failed oral required IV rehydration. So that gives you a number needed to treat for benefit of 3. That is a really good number needed to treat. So like I said, Ondansetron has changed my practice. I usually break up the 4 milligram dissolvable tablets that we have and give 1 in the department to the child, observe the child, and then I'll send the other half home with the parent. That's how we can do it. And I'll say give it to them in the next 8 to 12 hours if the symptoms persist, if needed, and return if you're concerned. Abstract number 7 is an observational study following the introduction of Ondansetron. So what's happened? How has it impacted practice? So this was 18 U.S. emergency departments, over 800,000 children. So of course with observational studies, it's often easier to get a bigger cohort. The age range was from 0 to 18, that's what they defined as a child, gastroenteritis, and they looked over a 9-year period after the introduction of Ondansetron. And the purpose was to see if the increased ED Ondansetron use decreased IV rehydration rates. So Ondansetron use increased significantly. It went from less than 1% when it first came out to 42% at the end of the 9 years. And then they categorized the different institutions into low users, less than 5% of the time, medium users from 5 to 25% of the time, and high users, or high institutions that used Ondansetron a lot, greater than 25% of the time. IV hydration was used in 19% in the low Ondansetron period and 18% during the high Ondansetron period. So there wasn't much difference. During the transition from low to high Ondansetron use, they observed no change in hospitalization, but ED visits, bounce backs, dropped. The number of children that had to come back to be reevaluated did decrease. The big problem with this study, a limitation, was oral Ondansetron was only provided in less than 14% of the children getting IV therapy. And so perhaps if it was used more often, it could have had a bigger impact. But we need a study to show that. So does Ondansetron result in prolonged QT intervals in children? No. All right, now that's a concern, right? That's the hypothesis that Ondansetron could increase that QT interval and cause cardiac problems. This abstract number 8 is an observational study, found no increase in this ECG parameter in children receiving 0.15 milligrams per kilogram IV. So they had a 4-month period of observation. They had 134 children. The children were defined under 14 years of age. They got serial ECGs on them, no increase in QT intervals. Now, the limitation is it's a small study and harms are often not that common and studies aren't powered to find harm. But even if it did, even if you did find a prolonged QT interval, that's a do, right? That's a disease-oriented outcome, not a POO, a patient-oriented outcome. You want to see, did it have a clinical impact if their QT interval increased statistically? All right, that would be a surrogate outcome, I guess a SOO, as opposed to a POO, a patient-oriented outcome. Did it have any clinical impact on the child? What are some of the conditions to predict failure of oral rehydration? It won't be universally successful. Like I said, the failure rate is around 1 in 5 to 1 in 4, and abstract number 9 documents a 21% failure rate. I like to flip that on its head and say, you know what that is? That's a 79% success rate for children. But in this study, they had 802 children, 1 month to 5 years of age with acute gastroenteritis, 21% oral rehydration failure rate. What was predictive? Sicker kids. If the child was sicker, the child was more likely to fail oral rehydration. Where was this published? The Journal of Duh? Anyways, all right, so starvation ketosis. It's common in children with nausea, vomiting, and diarrhea with dehydration. And for those with the correct combination of the nasal anatomy and the genetics, it's possible to smell the acetone. I don't really have a good sense of smell, which is a blessing working in the emergency department. Also, when we had young children and dirty diapers, no, I can't smell anything. But if you're a foodie, it's a terrible thing to have because I really don't have a good sense of smell, which also combines with taste. So if you can smell acetone on the child's breath, ketosis is a strong vomiting stimulant. Again, think DKA. So what's the relationship? Abstract number 10 is a prospective observational study looking at blood levels of beta-hydroxybutyrate and association with failure of oral rehydration. They had almost 250 children less than 14 years of age. They had to have vomited more than 2 times to get into the study in the preceding 4 hours. So it's under 14, at least threw up 3 times in the last 4 hours. Beta-hydroxybutyrate levels did not predict failure of oral rehydration therapy. And what was the success rate? 78%. I know they keep talking about, oh look, 22% failure rate. But I'm thinking the glass is half full. 78% success rate. Now, how do families and family members and the healthcare providers feel about oral rehydration therapy? It can be time consuming, right? You got to sit there and give a little bit at a time. And it requires persistence from the caregivers. Abstract number 11 found that parents preferred the IV versus the oral. They had 260 parents completed this survey, and they were asking the pros and cons of oral versus IV therapy rehydration. Now, this was done before rehydration of the child. IV rehydration this is what I want from the parent or caregiver, one hands down, 2/3 wanted it, 1/3 didn't want it. Of those parents who selected IV rehydration, so that's the 2/3 of parents, over half of them stated they would choose oral if there was an oral medication available that would significantly decrease vomiting. There is, Ondansetron. And of those parents who selected oral rehydration therapy, only 1/3 of them stated they would choose IV if there was a topical medication that would significantly decrease the pain of IV placement. Again, there is. You could put a little Emla cream on them. The next question, what are the options when oral rehydration therapy fails? Because it does, like I said, 1 out of 4, 1 out of 5. So options for these patients include an NG tube for rehydration that way, or an IV. Abstract number 12 is a Canadian pediatric study looking at 135 children, child-parent dyad, and 113 healthcare providers. So they surveyed them. If oral rehydration were to fail, 10% of caregivers and 14% of clinicians or providers would choose an NG tube. So the vast minority said, listen, if the oral doesn't work, both from the parent side and the provider side, if the oral doesn't work, I'm not too keen on doing an NG. Now, after a brief intervention, talking to them about this, the proportion of recommended NG rehydration increased to 27% among caregivers, so 1/4, and up to 43% among the healthcare providers. What are the recommendations for IV therapy in children failing oral rehydration? So if you are going to go with IV, not NG, but you're going to go with IV, what fluid should you use? So abstract number 13 addresses the question about adding dextrose to crystalloid therapy in dehydrated children. The literature review, unfortunately, only found 2 studies, total of 333 patients. So we don't have a lot to guide our care here. There was no statistical difference, though, in outcome, and with so few patients, there were wide 95% confidence intervals around that point estimate. Abstract number 14, in this section it demonstrates that when restoring IV fluids, the volume of fluid can range from 20 cc's up to 60 cc's per kilogram, like I mentioned earlier. So this was a systematic review, and there were only 3 trials that they could find, 464 patients. Most of the children had moderate dehydration. Like I said, the volume ranges were from 20 to 60 cc's per kilogram, so a wide range, and they were given either fast, like in the first 1 to 2 hours, or slowly over 2 to 4 hours. There was substantial heterogeneity, and so that heterogeneity means how much difference was there between the studies that were included. And remember, there were only 3 trials, and the heterogeneity was high. So you're comparing apples to oranges. There were no deaths in the study, so that's good. Safety endpoints were edema, only 6 children, and dysnatremia, so the sodium was off. That was only in 2 children. The pooled analysis of these 3 trials showed no significant difference between going rapid or slow IV rehydration in the groups of the proportion of treatment failures and readmission rates. All right, can Ondansetron be prescribed for home use? So can you send them home? I already said that I do this from time to time. Abstract number 15 demonstrates that home use of Ondansetron is safe, but does not appear to impact return visits for children with acute gastroenteritis. There were 12,000 eligible patients from 6 months to 18 years of age. 1/3 of the patients were discharged home with Ondansetron prescriptions. Again, I don't give a prescription, I just give them the other half of the tablet usually. There was no association between Ondansetron prescription and ED revisits among the children seen with suspected acute gastroenteritis. And then we have, does an algorithm have value in managing children with vomiting and diarrhea? So this is abstract number 15, and it gives you an algorithm. So you'll have that, and you can take it back to your institution and talk about it and see what you think. They had 30,000 plus children included in the study that looked at this. IV rehydration decreased from almost 50% down to 25%. So they cut it in half. It went from half to 1/4. So that's a big drop, right? So it's a 25% difference. If you use the protocol, the number needed to treat would be 4. The mean length of stay decreased, and again, that might be significant to your staff and to the efficiency of your emergency department. It went from 4 hours down to 3 hours. So you save an hour, you can turn that bed over quicker. All right, so let's get down to the summary then. Key points and recommendations from this nausea, vomiting, and diarrhea lecture in children with mild to moderate. Oral rehydration is comparable to IV fluids in children with mild to moderate rehydration. Commercial electrolyte solutions vary widely in the composition and may lack enough sodium for dehydration. The use of Ondansetron can reduce failure rates in oral rehydration patients, and Ondansetron doesn't increase the QT intervals on ECGs in children. More severe dehydration and higher triage scores are associated with more oral rehydration therapy. So the sicker kids are more likely to fail. Yeah. Starvation ketosis is not associated with increased failure of oral rehydration therapy. Family members may prefer IV over oral because oral can be time consuming and you have to be persistent. Most clinicians do not consider NG rehydration. And IV fluids with dextrose does not change clinical outcome compared to electrolyte-only IV therapy. And the final thing is Ondansetron prescriptions do not impact return visits to the emergency department. There you go.